kind of came a little close to that, where we did set up, screening stations, kind of shut down some of the entrances to the clinic. And, we did that for about maybe a month, and then we just kind of backed off. Now we're almost, 10 months into this thing, and it doesn't look like it's relenting so much, but some of the numbers are improving here a little here in San Diego County. But we're, as you guys probably heard, Los Angeles and Southern California was pretty hit hard in this last surge. And, obviously the holidays didn't help, Thanksgiving, Christmas, and New Year's. A lot of people were getting together, and the vaccine's just coming out, but yeah, I'm really glad to be here. I'm, just by hearing what everything that's been said, and what people are doing across the country, I'm really encouraged that we're all working at our own levels and our own ways, but we're helping our communities whereas nobody else would.
Thank you, Dr. Rodriguez. Thank you for your responses, and everything that you have said resonates. And I am quite sure that everybody is on the same boat, and at the same time we are learning together. So that's something that and that's the purpose of this type of activities. We are learning, and that's the best way to do it, while we have conversation with the health centers, and share best practices and challenges. And Dr. Rodriguez mentioned something really interesting regarding the vaccination, the staff vaccination. And Dr. Ramirez, you and I were discussing early before going live about vaccine hesitancy, not only among patients, but among staff. So what is your experience with the vaccine hesitancy?
Yes, we had the same experience as Dr. Rodriguez seemed to have had. We have people who couldn't wait to get the vaccine, and others that were no, 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 I'm not gonna get that. And essentially, the way we handled it is that I was the first one to get the vaccine at my health center. We got the Moderna, and people took pictures and they put it up on our internet, and everybody saw that it's okay, and everybody pretty much followed after that. But there were still some people that were hesitant and were just waiting to see how we reacted, like Dr. Rodriguez said, see if we tolerated it well, if we were still functioning. And in fact, I got, after I got my second dose, the people were asking me, how you doing? How you doing, Dr. Ramirez? And so and we were always going, yes, it's great. I mean, we tell them there are some side effects from the second dose, but something that's tolerable, and the alternative is definitely much worse. And the people are really coming around. So we are also around 70 to 75% vaccinated for our employees. We don't make it mandatory. And I think the vaccine hesitancy, as we overcome it within our staff, we can also help our patients overcome it. We get to know firsthand how we felt about it, and how relief. I mean, we felt an incredible amount of relief when we got vaccinated, and just reduce that anxiety that you were carrying around with since March in New Jersey. And then you can convey that to your patients and say, hey, we have this here, and like Mr. Taylor was saying, let's take the opportunity to vaccinate you. You're at high risk. We want to give this to you, and I recommend it. I'm your doctor. So we're trying to really push, promote it in terms of from the provider perspective as well.
Thank you, Dr. Ramirez. That's very, very, very useful. I'm going to stop for a moment and just need to check with our support staff whether we have any questions from the audience, either through Facebook or through Zoom.
We don't have any questions so far.
All right, thank you so much. Henry, another big issue is to build collaborations in the community. Work with the public housing agencies and with the other community organizations to establish either vaccination campaigns or education. So to make sure that the patients are receiving loud and clear the message. What is your health center doing to collaborate with the community, with your public housing agencies, or with other organizations in your community?
one of the, we're doing several things, and this is a very important topic as we look at trying to change the culture or the tip the scales relative to patients and community members wanting to get the vaccine. One of the things we're doing specifically with CHA is working through the process where we can share and hire staff. We are in the process, I have an MOU on my desk I'm reviewing right now to share a community health worker that's going to be specifically assigned to public housing in Miles Square to do outreach in the community to help get people living in Dearborn Park to our health center to get inoculated and to educate them about the issues related to good quality health, but in particular, vaccines. On a larger scale, what I've challenged the team to do is several things. One, well, we're working with our Latino and Black caucus to have town halls. We have had a town hall last Sunday. We have a program on one of the radio programs here in Chicago, and we featured one of our providers to discuss the vaccines and address some of the myths regarding vaccines. I always like to start off with our staff to say there's good reason why people are reticent. There's good reason why people feel fearful. And we have to start from that space, recognize the reasonableness of the fear, but talk through the science and why it's good health to get the vaccine today. When you consider the risk of African Americans, Latino Americans dying 2 times, 3 times more than the average population. So part of our charge is to do 2 things, a 2-tier approach. One, provide the service in the clinic and in the community, meaning in the inoculation and testing, and also provide the information forums for discussions to be held about good health, address fear, meet people where they are, and help educate them. I also think it's important to note is on the early onset of COVID, one of the things that came out with us was, came out in terms of data for us was food insecurity. The number of patients who were really food insecure as a result of the onset of COVID. So we established a partnership with one of our local grocery stores, with Blue Cross, and we were able to deliver meals to over 3,000 families throughout the COVID season. So looking at all of not only the health issues, but those issues that plague our children and our families while suffering through this virus. We're looking for other partnerships. I just got a call yesterday regarding a private investment firm who wants to make a donation to us, again, about how we could reach out to the communities to do testing. So we're open to all ideas and all volunteers who want to help us address this issue. One of to put it out there in terms of if anyone has a connection, what I would love to have is a van that I could take and have go around the community to inoculate and educate families or patients or citizens. Of particular concern, not only are people living in public housing who are well isolated, but also our homeless population. You know, when I drive to work every morning, I know we all see these tent cities throughout our community. Who's looking at, who's paying attention to these individuals? Who's asking the question about their health? So there's a lot of work still to be done. And last, I'd like to leave the community with the thought. One of the items I've shared with my team is we have to learn to manage in a COVID environment, meaning by that we must operate our practices. This is when it first started, I looked at it as an anomaly. Now I look at it as a part of our normal business in our practice, that we're going to have these outbreaks, these events that are going to disrupt us, but we must learn how to manage and thrive in these kinds of environment. I'm reminded as our physicians have talked about Ebola, but also the water incident in Flint, Michigan. That's what we do. So I hope that helps, Jose.
It does, and thank you so much for your response, Henry. And Bob, do you have any follow-up questions for the panel?
I have a number of questions which I set down here, and every time you guys open up your mouths, you cover them so thoroughly that I scratch them off my list. And I'm really happy that you talked about the managing angle of it. And I guess, combining social and I guess in a more detailed way, combining social distancing, at work and so many people teleworking at the same time, what additional steps or techniques have you had to put in place in order to manage your staff, in terms of quality control on one hand and then staff morale on the other hand, and just trying to get things done without having, the team in one place? So Dr. Ramirez or Dr. Rodriguez?
I can go real quick. I think that's a great question. And especially early on when it was a big unknown and, there was a lot of restrictions put in place, by the state or the county or the government in general, even the federal government. So our thing was to, ease people into it. Yes, provide the telework, easing them to things that that were unknown or that they had a lot of maybe anxiety or fear about. So we were compared to, before we're like, well, sorry, it's your job, you got to do it. End of story. We did a whole 180 on that, for the employees' benefit and sake. I said, whenever they want to test, let's test them. Even if they don't have the exposures, they don't have any symptoms, make testing available for everybody. Early on, that was super important. And we got a lot of, how can I put it this way? We got a lot of mileage, in terms of the morale department, by just things like that, not being, not coming in with a heavy hand, but rather just a little more understanding, listening to what they're saying, despite even if it didn't make sense, sometimes you still just go with peace, if they're peaceful in their mind and their heart, then they're going to be able to work, So we were able to acquire a lot of PPE, thank God, early on. We didn't suffer from that as many other centers did. So we were lucky with that. And so we were able to, provide the safety and the security. We went to probably overboard in the disinfecting process, like every high touch area was like every 15 minutes. I was like, wow, we were able to acquire all the disinfectants that worked against COVID-19, SARS-CoV-2. So that's some of our experience there in terms of the, employee morale and, the productivity, being able to keep that up.
And a similar question relative to reaching out to the public, because, I guess some of the key to dealing with hesitancy issues and just to getting people involved in community health in general is getting them to trust you. And in a situation where we still have social distancing and you're limited in terms of your ability to have that face-to-face interaction with, folks in the community, your patients, public housing residents and so on. How have you, what techniques have you used in order to reach out to people to deal with hesitancy issues, to advertise testing and, flu vaccinations and COVID vaccinations and all the rest, and also to get folks to come in for their regular healthcare maintenance? And Henry, if you've got.
Surely. One of the things we're seeing there are two responses to this. One, the initial onset of COVID, we deliberately dialed back our practice so that we only saw those who really needed to get into the clinic. So that loss was orchestrated or by design because we wanted to care for those who absolutely needed the care the most. As things improved and we got more information about the science and the impact of social distancing and the mask, we ratcheted back up and we opened up our doors in terms of seeing more and more of the patients, including the pediatric patient population. So we're seeing less concern today, or we see more, I should say it this way, we see more opportunities today to still see patients in real time and seeing them in person. We still provide an array of telehealth, virtual care for our patients. And what's important to note is I as we have these dialogues in our health center, one of the things we looked at was our health outcomes. We did see an uptick, quite frankly, due to, with COVID in our A1Cs. We saw that our families, their health was, so we wanted to be very, very mindful of what do the indicators show us, what's happening with our population in terms of their health outcomes as we look at modifying what we're doing in terms of telehealth and in-health visits, because that's, from a telehealth experience, you can't get necessary lab work. You need to get the families in for their lab work. So we've modulated our practice. So you're going to have to get into the clinic for us to see you in order to keep you well, so having absolute telehealth is just not the answer. A hybrid approach of both is really what we've come accustomed to. The battle right now for us is not so much in the testing. Everybody wanted the test. Mm-hmm. So that was not the issue for us. The battle right now is the vaccine hesitancy and communicating to our staff, not only just the hesitancy, but you sometimes think you have the best systems. We had a system and have currently a system where our patients can call in and get an appointment to get their vaccine. Mm-hmm. Well, as we look closer at the data, we're still showing that we're not getting, or those patients who are highest risk are still not getting in to the degree that we would like. Mm-hmm. So the challenge for us is ensuring that those those who need it the most are given opportunity to get into the clinic and get the test. So our staff we're calling patients, we're reaching out to them by telephone. And I share to our outreach workers and our navigators, you're not salespeople. I don't want you to sell this. I want you to make the offer. The sale comes by way of pointing to them to our community our community forums where we provide education about the issues associated with the vaccines and some of the historical challenges we've had with some of the issues our communities feel about, being experimented on. That's where we want that to occur. But we want to get to those families who want to get that vaccine, because I believe by way of mouth, the momentum, the scales will tip, but we've got to get that ball rolling to get more and more people who've had good experiences with the vaccine, who can tell their neighbor, tell their family members, and get them to move on and get the vaccine.
Thank you, Henry. It's almost the top of the hour. I would like to be very conscious of your time. And I know that Dr. Rodriguez has a suspected case there, so he needs to deal with it. Just a final question for all of you. And I would like to start with Dr. Ramirez. And again, this is evolving rapidly. We have new faces. And one of the things that one of the topics or issues that we were discussing with Dr. Ramirez was monoclonal antibodies and HHS trying to offer the alternative either through community health centers or any organization working with health centers, including long-term care facilities. So what is your opinion, Dr. Ramirez, on what is SUFA, or what SUFA can do or cannot do in regards to the administration of monoclonal antibodies?
Yes, so I say monoclonal antibodies were the only thing that we had before the vaccine to really help our patients who are really getting very ill and ending up in the ICU. So we were really interested in looking at that option at our health center, and I read into it and I saw what the requirements were, and I realized that health centers that may be more affiliated, like maybe Henry's Health Center, that have a more of a connection with hospitals or with an outpatient infusion center, were more apt to be able to be successful with this. It requires special areas where you have infusions of the monoclonal and observation. of the patient for an hour afterwards with ACLS certified nurses who can respond to any emergency. So it was definitely much more than we could provide. But we looked at it, and then we also looked at our community and so that our surrounding hospitals. We have 6 sites, or we have 11 sites, like you said, but we have 6 main counties that we serve, and very close to us, our hospitals were offering these at their emergency room. So we got very, very good at talking to our patients, explaining what this was, and sending them as soon as possible to the emergency room. And we've been very successful in getting a lot of our patients get this therapy.
Thank you, Dr. Ramirez. Henry, what is your experience in regards to monoclonal antibodies?
We don't offer that therapy in the walls of Miles Square, but we do have the systems, because we're part of a health system, meaning University of Illinois health sciences system, to transfer our patients to the emergency department and getting that care in the inpatient unit. So our connective tissue with the university allows us to do that rather effectively. Now, the one opportunity, and we've not evaluated, we do have an urgent care center that operates as part of our practice. And the question is that something we should be doing in our urgent care? And actually, I don't want to get too far out of my lane because I don't have MD at the back of my name. So I'll leave that to our physician leader to sort of come up with an answer for that for us.
No, thank you, Henry. And your experience, Dr. Rodriguez, in San Diego?
Yes, so definitely we heard about it here. Actually, I heard about it from our CEO. Send me some information. Plus, simultaneously we have been hearing about it from our consortia here, and just much like Dr. Ramirez said, those challenges of being able to, hang it, IV drip, over the course of it, the time that it takes, plus then the hour evaluation, you have to be ready for anaphylaxis. All these things are very limiting and, huge barriers that, we're not able to, surmount, or overcome. And the consortia has been able to work with one of the local hospitals to be able to set up an outpatient infusion center just for the community health center patients, or at least make it available to them, and others, of course, too. Like doctor said, we have very high risk patients, and the earlier you get this medication into them, the better, because once they start mounting their own antibody response and they start competing with the monoclonal antibodies. So it's, if you can identify a high risk patient early on, first few days of the illness, not a huge amount of symptoms, that's the ideal candidate, and that's also difficult because our patients come to us when they're a lot sicker, more than, than what it's recommended in terms of it being early on and, not much symptoms yet. So.
Thank you, Dr. Rodriguez. Bob?
Yeah, just have one final question for all of you, and it's really along the lines of this. We know that health center folks are busier now than maybe they've ever been. And when they've got the regular work plus COVID on top of it, as I think Henry mentioned, kind of the two tiers that you're trying to deal with. We're trying to provide training, technical assistance, partnership building, research, that kind of stuff. If you could tell us, briefly what you think, how we could help you in as efficient a manner as possible. What kinds of information, for example, is it clinical information? Is it reimbursement information? Is it supply information? Is it coordination information between, your state immunization program managers and your departments of public health? There's been talk about direct shipments, for example, directly to the health centers and all that kind of stuff. So in any of those areas, if you could kind of tell us the kind of information that you need, the kind of training, and also we're trying to do it efficiently. So, because we know people have such limited time. So what's the best vehicle or the best schedule for us to provide that kind of information? And, any guidance you could provide would be so helpful. Dr. Ramirez, do you want to start?
Yeah, that's a very good question. So what do we need, and how do we get it? It's so hard because there's so many different things that we're responsible for at the same time, like we're saying. I think that information is flowing. I think in terms of clinical information, I think is flowing. I think that perhaps the challenges that I find that really just distress our staff is how vaccine distribution is occurring, and how that uncertainty as to when we're going to get our next batch, and then once we get it, then we have to use it within 6 days. So we're getting 800 vaccines per week, and we're trying to figure out how to then disseminated quickly and everybody seeing the patients, telemedicine, in person. I'm doing the UDS. We're trying to vaccinate. We're trying to do COVID testing. We're trying to do, it's like, oh my gosh. So
Yep.
if that could be simplified and streamlined, or any kind of assistance with that kind of partnership, we are very grateful that the Department of Health has recognized us as a key member in the armamentarium. But we just feel completely at their mercy in many ways. So I think that relationship would be really good, the communication with the state. And obviously this is bigger than what you can. I think just the inability for the United States right now to have enough vaccine to 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 uh, to meet the demand is the problem here. And I think that's one of the issues. But that's one thing I would like.
Yeah, and I totally agree with Dr. Ramirez. Yeah, we're trying to stave off the county from trying to take vaccines that we haven't been able to use, that we're going to be able to use next week, but they want them like before we can use them next week. After our staff, like it's been mentioned on here, calling patients, and it's only 65 and older, so we have a limited patient population group, and then a lot of them have fears and concerns, don't want them, and what have you. So it's been difficult, so we feel maybe some realistic, communications with the county and the state, and also the state sending us vaccines, and then the county wanting them to take them away from us because we haven't been able to meet that 65% quota. So we've been on the phone today with the county, and we're, I'm hopeful that we're going to be able to hold off on them asking us to give some back after they just sent us some. The state sent us some, and the county wants them back. So I don't get it. I think the state and the county need to also communicate better, and then let us have the final say, like, hey, look, here's the action plan. In a week or two, we'll be at the levels that you want us to be. It makes no sense sending us vaccines and then asking us to send them back. Like, you guys are wasting your time. You're wasting our time.
Are the primary care associations in your states any help on that issue?
They've been getting involved as well, but in terms of this particular issue, I haven't seen the email chatter or the communication yet. It's possible that they have been as we're speaking now, because they usually end up seeing a lot of updates at the end of the week.
Yeah, so dynamic. Henry, any training needs and modalities?
Yeah, this conversation has been extremely helpful. So I would say, Bob, starting with two particular issues. One, best practices, because we don't have the Moderna vaccine quite yet at Miles Square. But to hear my colleagues who already have it and are struggling with all of these key issues, and so learning the best practices or how you went implementing the vaccine process really saves me from having to start from ground zero. So being able to learn from my colleagues, and if that could be documented in terms of workflows and processes, we can share those across the nation. So that's one phase. The second phase is leaning forward, thinking about what happens coming out of this or living in it over the course of time. And that is, how do we look at our workforce going forward and training them to be prepared for these kinds of circumstances? And how do we work with our congressional leaders for funding to ensure that there's more training in community health centers, so we can get folks like the doctors in front of me today who will want to work in community health centers. So I think that's part of what I'm walking away with as part of this conversation, that there's such a need and will continue to be such a need in the future. We are the future in terms of healthcare, but we have to have resources and individuals who want to work in our environment. So having that focus, I think, is going to be paramount for us.
Yeah, well, thanks very much for that. And Jose's always saying, hopefully soon it'll be time to start working on life after COVID. And, hopefully, with all the good work you're doing, we'll be able to do that. But I'm going to turn it back to Jose.
Thank you, Bob. Well, I would like to thank you, Dr. Rina Ramirez from ZUFA, Mr. Henry Taylor from Mile Square, and Dr. Javier Rodriguez from La Maestra for your time, your support, and sharing your experiences. This has been very helpful to all who have been attending or who have been on either through Zoom or through Facebook. This session was recorded, so we are going to share this with all of you, and it will be posted on our website. So thank you again, and have a great afternoon, great evening, and have a great weekend. Thank you.
Thank you very much.
Thanks,
Bye,
everybody.
guys.
Fun.
Thank
Good
you.
one.
Thank you.
Bye, everyone. Be safe.
Two.
Thank you.